Welcome, everybody. Welcome to another episode of PEM Rules, Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual. And today, again, more important rules in the clinical care tips category. Rule number 147. Know how your consultants practice. So this is something I learned from experience after practicing as an attending for several years. It's actually a very important rule that just helps you do a better job and helps you facilitate your care without delays. As an emergency physician or an emergency clinician, I often consult other specialists or at the very least talk to a hospitalist in order to admit my patients, and I think it's always a good idea to know how they practice and, in a way, speak their language. Again, always a good idea to give examples. When I arrived at Florida in Orlando for the first time, I discovered that after working up patients for appendicitis with an unsuccessful ultrasound that does not visualize the appendix, the surgeons at the facility where I was working really liked the pediatric appendicitis score, which is basically a combination of physical exam findings and history with a CBC, which is always easy to obtain for the most part. And they like to know what the pediatric score is in order to decide if the patient needs a CT, if he or she should just be admitted for serial abdominal exam, etc. So after practicing in Orlando, Florida for several months, I got into the habit of obtaining CBC and an ultrasound in all my patients with suspected appendicitis, and if the ultrasound was inconclusive, which happened about 50% of the time, I will always call them with a score that they like to hear and that facilitate the patient's care and the decision made by the pediatric surgeon whether to admit, obtain a CT, etc. This helped me take better care of my patients and facilitate the efficiency of my care. So if you know that your surgeons like the pediatric appendicitis score, do that on the patients with suspected appendicitis and report it to them. If the pediatric ICU attendings in your facility like to get a chest x-ray on all kids with respiratory symptoms, do that. Otherwise, when you call the PICU for admission, all you're going to get is a request for a chest x-ray, which you haven't done, and that will delay the care of the patient. So if you know the PICU or the hospitalist or your consultants have a certain preference, speak their language and know how they practice. Another example, again, in my previous job in Orlando, Florida, the pediatric hematologist felt that younger patients with sickle cell disease pain crisis should always be admitted. In his opinion, they were high-risk patients for complications. I'm sure he's right. He knows better than me. In that population, I used to be very conservative and basically get the full workup and admit them every time they presented with a pain crisis, even if they looked well, even if the vital signs were within normal limits. So knowing how my hematologist or oncologist practiced helped me do the right thing for my patients and facilitate their care without delays. Of course, it's always a good idea to follow up rule number 27 and make your own assessment and plan and share it with the consultants as opposed to call and say, hey, your patient is here, what do you want me to do? As I mentioned, it's the same for the hospitalists. Some hospitalists are a little bit more conservative or perhaps inexperienced than others and sometimes want more workup prior to admission. Knowing what your hospitalist's preferences are helps you do the right thing, obtain the necessary studies or labs or imaging that you know they're going to want, and facilitate the care of the patient with no delay. So follow rule number 147 and know how your consultants practice. Rule number 148. Think outside the box. This rule is obviously easier said than done, but oftentimes we anchor on the differential diagnosis that comes to mind first. We see a patient and we kind of anchor on what we think he or she have without opening our minds and without thinking outside the box. Again, always a good idea to explain with some examples. My favorite example for this rule is a patient or a child that presents with a limp. I think we very often anchor on musculoskeletal complaint or musculoskeletal etiology for a child with a limp. But it's very important in the appropriate age and the appropriate history and physical exam to think about it. Leukemia and the limp is secondary to bone marrow pain. Maybe if there is fever, this is osteomyelitis. All those are clearly more rare than a musculoskeletal complaint, but it's very important in the appropriate context to think outside the box. Another good example is the child who presents with vomiting, especially vomiting only, with no abdominal pain, with no diarrhea. Under certain circumstances, it's very appropriate to obtain CT head and worry about intracranial pressure causing vomiting. Another example I've seen before is the child who presents with tachypnea with no other respiratory symptoms, no wheezing on exam, no runny nose, no cough congestion. Under those circumstances, I've seen several cases when the child actually had DKA. So always think about the non-obvious differential diagnosis and always think outside the box. Rule number 149. No antibiotics without proof of bacterial illness. So those of you who have listened to PEM rules before know that I'm very passionate about antibiotic stewardship. I'm not a big fan of antibiotics. I'm not a big fan of giving antibiotics without having a proof that the child is actually sick with a bacterial illness. A good example is the patients that I see who came from the primary care and were started on antibiotics based on auscultation that suggested the child had pneumonia. I always teach my medical students and my residents and my fellows now that if you think the child has pneumonia, it's always a good idea in the United States 2023 to obtain a chest x-ray and see if there's actually pneumonia. Obviously, that's very easy in the emergency department, but for those primary cares or any physicians or clinician who are worried about pneumonia, it's very easy to send the patient to the emergency department with that concern. We can always obtain a chest x-ray very easily and see if the child has indeed pneumonia. But starting a child on 10 days of antibiotics with no chest x-ray, with only history on physical exam, nowadays, I don't believe is the right thing to do. Getting a chest x-ray for the most part is an easy thing to do. It's available in most emergency department, obviously, and even in some urgent cares and even in some primary care offices. So if you think your child has pneumonia, please refer them to the ER. We can always get an x-ray and prove pneumonia, no pneumonia, needs antibiotics or does not need antibiotic. Another good example for this rule I thought about a few months ago when one of the ED residents presented a patient with a sore throat. He presented a patient that had clearly lymphadenitis on exam with no exudate, some fever. He recommended getting a rapid strep, which I completely agree with, although the physical exam were not exactly consistent with that, without exudative pharyngitis, etc. However, rapid strep is easy to do, fairly sensitive, so of course we did that. And after the rapid strep came back negative, the resident still suggested we give antibiotics to the child for 10 days and treat him for strep, even though the test was negative. While I completely agree that rapid strep is not the end-all be-all and it's definitely not a gold standard, however, it's about 85% sensitive and it's all we have, I do not see a reason to condemn the child for 10 days of antibiotics when the test is actually negative. Most likely, statistically speaking, the child is viral pharyngitis and the negative strep strengthened that hypothesis. I see no reason to start a child on antibiotic with a negative test. So in my mind, I start a child on antibiotics when I have a urine sample indicated UTI, chest x-ray indicating pneumonia, etc. Of course, there are exceptions to any rule. As we discussed in the podcast before, if I obtain a blood culture for whatever reason, I certainly give 1 dose of ceftriaxone since the results of a blood culture is not available for me for 24 or 48 hours as an emergency physician. I don't believe it's the right thing to do to hold antibiotic on what could potentially be a medical emergency such as bacteremia. So under these circumstances, I certainly give antibiotics blindly. But please remember rule number 149, no antibiotics without proof of bacterial illness. Certainly that proof may not be the most sensitive and specific test. However, if that's all you have, if the test is negative, I see no reason to start antibiotics. And that is it for today, guys. Thank you very much for listening. I hope you liked the episode and I hope you continue to listen to PEM Rules. Please check out EP Monthly for my new articles in the column for pediatrics. And please continue to check out the website and submit any feedback you have. I've gotten great reviews recently and always get new ideas from you guys. If you want to comment the show because you had an interesting case and apply the rules, you're more than welcome to. Let's briefly review what we learned. Rule number 147. Know how your consultants practice. Speak their language, provide the testing or the x-rays or the lab results that they usually want, and facilitate the care of your patients. Rule number 148. Think outside the box. Again, easier said than done. Try not to anchor on the first thing that comes to mind and think of what else can explain this clinical picture, even though it's a rare etiology. Rule number 149. No antibiotics without proof of bacterial illness. Again, easier said than done, but for the most part, especially in the emergency department, we have a whole slew of tests that are available for us, and usually, if those are negative, they indicate the patient does not have bacterial illness, and there is no reason to start on antibiotics with a negative test. Again, easier said than done sometimes, and certainly different doctors may feel differently. This is my approach and my little contribution to the very big problem of antibiotic resistance. The following outro is a wonderful song by one of my favorite bands, Greta Van Fleet. Great voice, great guitar riff, great sound. Hope you like it. Take care and see you next time.